And if the neurogenic bladder and bowel is not well managed, it's not only the indignity of incontinence episodes that the person has to live with, but it will inevitably lead to a cascade of other health issues, recurrent bladder infections, autonomic dysreflexia, or just autonomic responses that can cause excess sweating and other issues. It will lead to poor skin integrity and possibly periods of long bed rest, and even respiratory infections for those with tetraplegia and high-level paraplegia if constipation then becomes a problem. All these complications don't only have a high cost to the NHS, but an even greater cost to the individual in terms of their physical and mental health. Now, innovations within the area of continence management, in my experience, have been mainly focused on upgrades to catheters and then in recent years, transanal irrigation systems. And since being developed by Professor Brindley and the team in the 1970s, the sacral anterior root stimulator, or the SARS, which is much easier for me to say, has been used worldwide in over 3,000 patients. But it hasn't always been widely used and implanted in the UK. And for a number of reasons. One were that trained SARS surgeons did retire. We're actually really pleased to have one of our support network volunteers join us today, Graham Rudd. He had an implant surgery some years ago and is still using his implant today, and he's going to discuss with us his experiences of using the device. And since 2020, there's been a renewed effort to offer the service to people living with spinal cord injury in the UK. And again, we're really pleased to have with us Dr. Sean Doherty, who himself has tetraplegia. He's had that for 14 years, and he's a researcher at the University College of London, and he's going to tell us more about the SARS system. So Sean, when you're ready, if you want to take over, thanks.
Yes, great. Thank you, Carol. I'm going to share my screen and go through a few slides just outlining what the sacral anterior root stimulator is and how it's been used and some of the results over the years, and just touch on some of the research efforts to try and improve the system to make it more widely available. Bear with me a second. If any of you had joined previously a webinar back in February, there'll be a bit of recap of what we covered there. And also, if you have any questions whilst we go along, I'll be very happy to have an interactive session or a chat if you want to either unmute or put something in the chat. Okay. Carol or Graham, can you just give me a thumbs up?
Yeah, you're good. Yeah.
Okay, cool. Okay, great. So as Carol suggested or outlined, I'm a researcher at University College London, where I've been for 7 years in a small research unit called SIA Create, which is right next to Stanmore Spinal Injury Centre in Stanmore at the Royal National Orthopaedic Hospital. My research is primarily focused on continence or urinary continence and methods of electrical stimulation to try and control continence for people with neurogenic bladder, in particular neurogenic detrusor overactivity or bladder spasms as an alternative to medications or Botox. So that's work that we've still got going on, and if you're interested in finding out more about that, we have trials continuing using wearable devices, but that's not what I'm going to talk about today, because for the last 18 months I've been on a government funded secondment at a company called Finetech Medical, who manufacture the Finetech Brindley sacral anterior root stimulator implant to restore bladder and bowel control after spinal cord injury. So this secondment's really been as part of a, as Carol said, a renewed effort in the UK to try and firstly make this device available for people who it's suitable for and who want to have access to it. So this is an effort alongside some clinicians in Stanmore and Oxford and the Walton Centre, but also looking at its availability worldwide to make sure that it's available into the future, as there's a lot of regulatory hurdles for implantable devices which have been changing over the last few years. A lot of my work's been trying to find a good route through that so that it's available to people who want it in the future. So firstly, just to go into a little bit more depth of what Carol was talking about what neurogenic bladder is. I know pretty much everyone on this call has an in-depth knowledge of what it's like to have a neurogenic bladder, but essentially the bladder has two functions. It needs to store urine and it needs to void urine. So it's pretty simple, and the structure is pretty simple as well. It's a big stretchy dome of smooth muscle which slowly fills up and stretches with urine, and it's held tight at its exit by a sphincter, which allows you to maintain continence whilst you're storing urine. And then when you want to void urine, naturally you would release the sphincter, opening the exit, and then squeeze the big detrusor muscle, or the bladder. So it's pretty simple to look at, but its control is pretty complicated, a bit like one of these funny machines. It involves interaction between the autonomic or the automatic nervous system and the voluntary nervous system, which is a unique property for a visceral organ. And it also involves interaction between all these different areas in your brain. So all of the effects of kind of needing to go for a wee when you're feeling a bit nervous or cold or hot, they all interact in different ways and affect bladder function. So the difficulty with this is that there's a lot of different places for it to go wrong, and spinal cord injury really interrupts kind of bang in the middle of the communication between all of these centers in the brain and the centers in the bottom of the spinal cord, which coordinate the two muscles. So we end up in a position following spinal cord injury where there are overactive reflex arcs which cause spasming in either the bladder muscle or the sphincter or both. So there's a loss of coordination between the two muscles, and these two things lead to either incomplete emptying when you do try to void the bladder, or very high pressures within the bladder, or complete incontinence whilst you're trying to store urine. So it's really not very good at either of these two functions. Other things are sensory feedback is often disrupted, particularly following complete injury, leading to difficulties in knowing when to go to the toilet. And there's a loss of this voluntary control or drive of switching between continence and voiding phases. So there's a few issues to solve, and really we know all of these things. This is a slide I often put in to try and outline to other researchers what the actual problems might look like following spinal cord injury, but it's a real mix of social and medical complications that arise. It can be embarrassing. It can lead you to plan your life around kind of when to hydrate yourself and where you're going to go in your day out to find the toilet, and medical complications like skin breakdown with recurrent incontinence or kidney failure if you've had really high pressures within the bladder for a long time. And access is obviously a huge issue. But from the medical side of things, what do we care about? It's the preservation of the upper urinary tract is really paramount. So that's why you may have often had your urologist moaning to you about having to do urodynamics to measure bladder pressures and taking medication in order to reduce those pressures. So they really want to see low pressure within the bladder and low residual volumes of urine after either catheterizing or voiding. And for people with spinal cord injury, generally my experience and the feedback we've had is about maintaining continence and reducing that kind of fear or the result of leakage, having certainty about where you can go and predictability, being able to manage it independently, easy and discrete kind of methods of managing it, a feeling of it being natural and not having kind of, I've got a slide I often use, which is the engineering solution to incontinence, which is a man riding around a toilet go-kart so that he's got his kind of continence solution wherever he goes. But that's not really a natural feeling way of managing incontinence. And people want control, so they know, again, this kind of certainty of being able to deal with spasms in the bladder or needing to empty the bladder. And finally, an important one is no infections, because they have such a huge impact on our quality of life. At the moment, we manage storage of urine or bladder spasms predominantly through, firstly, medications such as oxybutynin or mirabegron, which are either antimuscarinics, or mirabegron's a new type called a beta-3 agonist, or injections of Botox into the bladder muscle itself, which has been really successful for a long time, but a lot of people do have issues with becoming either resistant or it no longer working so well after a period. And we don't really know what the long-term effects are over, say, kind of 20 or 30 years of repeated Botox injections. Many of us catheterize, either intermittent catheterization or suprapubic long-term catheterization or indwelling urethral catheters. And some people may use reflex voiding, so using those overactive reflexes to empty the bladder either into a kind of bottle or into a sheath drainage system. And the topic of today is sacral anterior root stimulation, which, as Carol said, has been used quite widely worldwide by people with complete spinal cord injury, but only in a few hundred in the UK over the last 40 years. And cystoplasty is another, so that's this surgical enlargement of the bowel, which is quite, I think, quite comparable to level of invasiveness to the sacral anterior root stimulator. So it's really a last option for people who are struggling with bladder overactivity. They might have a bit of bowel stitched onto the bladder to reduce those spasms and make it physically much larger. And they might have a diversion where, for example, the Mitrofanoff procedure, where the entrance to the bladder is located through the kind of tummy so that you can easily access it for catheterization. So that last bit was, I still don't think this is good enough, and nor do many people living with spinal cord injury. Some of our relatively recent, in the last 10-year academic studies have shown that about 50% of people with spinal cord injury are still struggling with incontinence issues, at least monthly, but many daily. So I think there's a big need for kind of more solutions for people to have access to. I'm going to skip on from this, but this is just another study outlining where people's priorities lie for research efforts, and that bladder, bowel and sexual function, whilst I'm not sure they should always be grouped together like that, they lie quite high, particularly in people with paraplegia. So the Brindley procedure, or sacral anterior root stimulation, is now often combined with a procedure called sacral deafferentation, which is a cutting of the sacral sensory nerves to disrupt this overactive pathway and that's really targeting the storage phase and trying to improve people's continence and to get rid of this spasming of the bladder and sphincter that people experience, so that the stimulator can work for voiding the bladder and bowel without having to worry about the continence phase. So sacral anterior root stimulation basically works by implanting electrodes which allow you to stimulate nerves onto the S2, S3 and S4 motor nerves as they exit the spinal cord. So generally there is a gap between around T12 and the sacrum, where the cauda equina sits, where all of the nerves that come out of the spinal cord and run down to the bladder and bowel are located before they kind of exit the spine and run to their target organs. So it's in this bit where the cauda equina is, where the electrodes are implanted. And the implanted electrodes are routed round, as you can see on the picture on the right, to a small receiver block, which is essentially some passive electronics, which then receive impulses from an external equipment box, which Graham will talk to you about afterwards, which essentially provides power to the system and stimulates the nerves. So how does this work? So for bladder emptying, we use something called post-stimulus voiding, which is a slightly artificial way of emptying the bladder and aims to overcome basically co-contraction of the two muscles. So instead of emptying in one big flow, most patients with this system would empty in a series of spurts of urine. So the system works by doing bursts of, say, 5 seconds of stimulation and then waiting for the in-between bursts for a few seconds for the bladder to empty. And this would be repeated several times until the bladder is empty. I've got a little video from a model called Henry, who uses he's a sausage dog with a spinal injury, who uses our veterinary version of the system and is much more willing, or at least he's not able to complain about us videoing him. And this basically just shows that bursting of stimulation. And you can see where the bladder's contracting and emptying the bladder. And there's Henry. Okay. Seems to have, oh, there we go. So the secondary aim of the sacral anterior root stimulator is to improve bowel management. So nerves are stimulated such that the bowel also contracts whilst the sphincter relaxes. So this works in a similar way to the bladder, only it works much slower. So you can see this graph on the right where the white bursts show when the stimulation is on, and then the red line is the pressure in the rectum slowly going up and down between bursts of stimulation. So bowel management is not a primary indication of the device, and generally it's not implanted in people solely for bowel management at the moment. And that's because it's not as reliable as the bladder management. So whereas for the bladder, generally about 80 to 90% of people carry on using the stimulator for in the long term, in bowel management, we've seen it's closer to 70% of people using it for bowel management. And Graham, I think, can talk to you a little bit about how he uses it. I would say that actually we should be looking closer at how we can implant this primarily for bowel management as well, because people who it does work well for really really like it, and it has very high kind of satisfaction scores for when it does work, and people tend to use it for a very long time. So just a quick summary of the system. The aim is to restore bladder control after complete spinal cord injury. It can assist with bowel evacuation, either as a primary, so the sole way of emptying the bowel, or as a method of bringing stool down into the rectum to be removed digitally. It can also be used in men for on-demand erection. However, this is generally only used in about 30% of men practically, because you have to hold the stimulator in place in order to maintain the erection. It's worth saying that the sacral deafferentation, I've not included a slide on this, but this is kind of certainly an area to research and talk to the clinicians about if you are interested. Sacral deafferentation has positives in that it's really drastically improves continence and improves bladder capacity back to kind of quite normal or very large volumes. However, it does remove reflex erectile function and reflex ejaculatory function in men if it's present. It's not for everyone, and it does remove reflex bowel function, so you won't respond in the same way to suppositories if that's how you're managing. And again, Graham can talk about some of the practicalities of that in the long term. So the system, the benefits really are the elimination of urethral catheters and the decrease in associated urinary tract infections. And it can improve continence bowel function and be used for erection. So just sorry, my computer's being a bit slow. Just a couple of slides on what it looks like in the long term. So this slide is just presenting a follow-up study done by the Swiss Paraplegia Centre in Knoxville, who implanted several hundred patients, but followed up 137 patients who were still alive in 2014, with a mean time of follow-up, so an average follow-up time of 15 years, but a range of between 1 and 25 years. And they found that 78% were still using the device. And this sits kind of in the middle of all of the other studies that have been published from different places around the world. And their main finding was a big benefit in reducing urodynamic risk factors. So this is really quite focused on the urology community, and they're worried about high pressures and low residual volumes, and it was found that that continued to have benefits for the group, reducing those risk factors. So the other study is one from last year, which is a collation of all of the articles that have been published following up people with spinal cord injury who have had this implant. And this looks at a cohort of about 1,100 people who have had implants across 34 different articles. So quite a lot of those articles were reports in the first kind of 5 years following implantation, but some of them, like the last one, were doing much longer follow-ups. So just as a general kind of guide, about 30% were tetraplegic and 70% paraplegic, and 89% had clinically complete spinal cord injury. About 86% were still using the implant, and this bladder capacity increase was generally, or on average, but from 180 milliliters to 480 milliliters. So that's the effect of this deafferentation, so the cutting of the sensory nerves. And the UTI decrease in the largest cohort was from about 6 episodes a year to 1 episode a year. And that's the effect of the kind of removing the need for catheterisation. And as I said, about just under 70% still using the device for bowel evacuation. And another positive of the deafferentation, so the cutting of the sensory nerves procedure, is abolishing autonomic dysreflexia related to bladder and bowel. So in Germany in particular, they do use this procedure also for people who are having problems with autonomic dysreflexia. So I'm going to whiz through these. It's how can I access this in the UK? We, at the Walton Centre, in collaboration with Mr. Sonny at Southport Spinal Injury Centre, they've recently re-established a sacral anterior root stimulator clinical service. So both doing new implantations and repairing old implants which might have failed, and also following up patients. So this is from Deepti Bhargava, who's the lovely neurosurgeon based at the Walton Centre, who set all of this up, and she accepts referrals from other spinal injury centres or from patients themselves. And the general route to having an implant is that you would have an introductory clinic with the team there to find out kind of whether you're suitable or not, and what you're whether you'd be interested, and having more information and discussion on those positives and negatives that I've discussed. You'd have to have some investigations such as MRI or CT and urodynamics to determine your suitability. And then Deepti's established a multidisciplinary team, which has urology, neurosurgery, scientists, kind of neuromodulation, and rehab and physio input to assess individual cases. And then you would move to either making a decision of whether you want to go ahead or not and having the implant. We have two other services. One is currently available, and that is at the RNH in Stanmore, and it's led by Mr. David Baxter, a new neurosurgeon there, and Dr. Sarah Knight, who's been a scientist who was my PhD supervisor actually, but does a lot of urodynamics and work around electrical stimulation and bladder control. And they have a functional assessment and restoration service, and again do a mix of new implants, repairs, and following up old patients. And you can also request a referral there if you're interested. And finally, a surgeon in Oxford is trying his hardest to establish a new or a replacement service for, I think it was Mr. Peter Teddy's service back in the early 2000s. And they're in the process of setting that up, but waiting for funding approval from the NHS. So at the moment, there is services in Stanmore and in Southport, not Southport, sorry, Liverpool at the Walton Centre, who accept referrals from other places. What's the time? Shall I go? I'll very quickly touch on some of the research we're doing outside of FineTech. So one is looking at using these implants to control continence without the rhizotomy, where we basically use a different type of electrical stimulation to stimulate the sensory nerves. And doing this, we're able to immediately suppress contractions of the bladder on demand. So this is really looking for a route to having a device that's suitable for people with who either don't want to have a rhizotomy, or people with incomplete spinal cord injury or bladder sensation, where they're able to turn on the stimulator on mode 1 for continence, and then turn the stimulator to mode 2 for emptying the bladder. And this is something that we've been working on for a while, but we have a a trial currently available in Oxford, which is looking to try some techniques on people with a Brindley implant already, if there's any of you out there that would be interested. So this is looking at kind of moving away from that bursting voiding to a continuous stream by using a new type of stimulation. And there's a trial, I don't think any of you will remember Professor Graham Creasy, but he was one of the surgeons originally involved up in Scotland, who's leading a trial in America looking at this same technique, but with new implants. So the other thing I've been working on and is looking at other applications of the implant, and one is around spasticity management. So again, we know that stimulating the sensory nerves around the sacrum can provide some relief from spasms, and this is something that we're developing projects on at the moment. So with an aim of including this as a kind of outcome using the same device. And another one is looking at pressure management and building muscle bulk on the buttocks using the same type of stimulation. And we've had a previous study in Stanmore that's shown that people with existing implants can use the device for FES of the gluteal muscles in order to improve blood flow and build muscle bulk. So that's everything from me, but I'm happy to kind of answer any questions, or we could go straight to Graham, who is been using the device for almost 30 years, I think.
We've got no questions currently in the chat. So if we go to Graham now, and then hopefully any questions that people may have in their minds will be answered. And if not, then we'll open the final 10-15 minutes or so to questions, if that's okay with everybody.
Okay, right. Hi folks, my name's Graham Rudd. I'm a T4 complete paraplegic, live up in York. I'll apologise in advance if my spiel isn't as quite as polished as Sean's is there. It was very impressive. Mine will be a lot more ad hoc, but I hope it answers any and all of your queries that you have. I suffered a T4 accident as a result of a motorcycle accident in 1977, and after 3 months, 4 months rehab in Pinderfields, Wakefield, I was lucky enough to go straight back to work. I was a civil servant at the time, so everything was very, very easy. I then initially I had an indwelling catheter at the time that suited my lifestyle, whether it was laziness or naivety, and that resulted in years of UTIs and frustration with.
I can't show the picture now.
Sorry, what was that? Someone coming in there, I was. So that suffered, I suffered years of UTIs and frustration, and from a young man with young man's wants at the time, it also doesn't work for me. I finished up having, as Sean touched on, what do they call it? The urodynamics sessions at Pinderfields, and they found my bladder was such that I was very suitable for this new device at the time, this SARS indwelling sacral root stimulator, which sounded very, very science fiction-y to me at the time. It was myself and one other guy were the first in the north of England to not pilot it, but to kind of benefit from the experiences I think they'd had down at Stoke Mandeville with it. And after long consideration and discuss with my partner, we decided it'd be a good move to get away from any device down there in between my legs, so to speak, if you're with me, to have this and to be continent and free of any intrusions down there. The surgery was done by Professor Brindley himself, along with the assistance of the urologist at the time, Simon Harrison at Pinderfields. Professor Brindley was an amazing chap. He was about, he must have been about 5'2", in his 60s, receding hair, a very, very smart grey suit when I saw him, with this massive pair of kind of gangster rappy baseball boots he used to wear. And in speaking to him, he's a real character. He used to compete in the Olympics of some description at pole vault, all of about 5'2" of him, a real character. Anyway, I digress. So we had the operation. It was inserted, as Sean touched on, in the sacral roots around the base of the spine. So I didn't see anything of that really. It was all behind me, obviously. I think I was only in hospital a few weeks before I was back home for another week or two before I was able to go back to work. My external, this is the box of tricks which you saw a picture of, and that's the transmitter. And there's effectively one of these transmitter receivers just underneath my left nipple, almost underneath my arm. So that's where I put the camera right. So that's where I stimulate to as and when I use the device. So I had that fitted in 1994, I worked out. So it's 28 years old. And I think at the time it was very, very new, and they thought it might last 10, 15 years, possibly longer. But 28 years down the line, I'm still using it to this day. So I've been very, very pleased with it. It certainly negated the UTIs, or put a huge stop on UTIs, because I was getting a far better empty with it. I used to use it kind of holding, if I can do it here, with one hand anyhow. I'd put number 1 for urine empty, and on the other hand, I'd have a bottle in between my legs, penis in, voided into a bottle. So it was always a case of needing to find somewhere private to do that, and carrying a bulky bottle around. At work and at home it was fine, but in other locations not quite so easy. You could effectively sit on the loo and void downwards into the loo, but what I found easiest, when I went out to a restaurant, bar, gig or whatever, I'd wear a sheath with a leg bag on, and then even through a shirt, through a top, I could just sit back, shuffle my bum a little bit forwards to give some space underneath the top of my thighs and my bottom, and I could put that on over my top and stimulate and wee. I had the other hand inside my trousers, and I could feel the flow of urine going through the sheath into the bag, which after half a dozen zaps, as I would call it, would stop, and I knew I'd had a wee in my portable loo, if you like, on my leg. I could do it in a corner of a room in the quiet, or just take myself away somewhere. So I found that very, very convenient. In due course, over many years, probably 15 years later, I was starting to get a little bit of leaking when I had a full bladder. If I leant over to pick something up, a little stress incontinence, I might have a little dribble. So I subsequently at that time then had a hydraulic bladder cuff fitted, which is another fantastic device. It's an artificial cuff around the bladder with a drain tube somewhere inside to a fluid reservoir, and then there's a tiny little pump in my testicles. So when I pump that pump in my testicles, that opens up the bladder cuff, and then you could then use the stimulator to void again. So that 15 years down the line, that was just a kind of belt and braces of further device that made me kind of more continent and dry. And the thing I loved about the whole thing from day one was having nothing on effectively in bed at night, just to go to bed free of any device until I decided, like I do at 3 o'clock in the morning, every morning, like 3 o'clock this morning, the alarm goes off. I just pick the bottle up at the side of the bed, put this device and wee where I'm lying, and then put it to one side, and that's me done, and I'm asleep 5 minutes later. the number 2 function of it for the bowel emptying, again, for 10 to 15 years, that was 100% effective. I used to go every night and used to take 10, 15 minutes. I think the use of the device during the day, even when I was just having a wee, gave some partial peristalsis to the bowel. So by the time 6, 7 o'clock on an evening, I was ready to go. So I would sit on the loo and with a K-wide gloved finger, I'd remove what was there, stimulate for 2 minutes, empty, 2 minutes, empty, 2 minutes, nothing there, another 2 minutes, nothing there, another minute, nothing there. And I knew that was me done. And it was very clean, very quick, very slick. And that worked for a lot of years. Again, down the 15, 18 years down the line, I think that peristalsis all but stopped, and I now use an anal irrigation kit every other night, which is very good, very efficient. But when I think I'm done, I'll have a last minute 2 or 3 minute stimulate with this, and it will just seem to kind of flush out anything that's there, even if it's just a bit of gas. It seems to kind of stimulate that kind of lower part of the rectum or some part of the bowel, and it'll just finish off again. So it's I know I'm safe and well for the next couple of days, really. Certainly UTIs and the autonomic dysreflexia, I remember, yes. I've had one bout of autonomic dysreflexia, I think, since my injury 45 years ago when I was 18, and that was pre using the stimulator. So by look of design, it's had a, I've stayed well clear of autonomic dysreflexia. I'm just looking at my notes here whether there's anything else I want to touch on. I didn't use the function 3. Sean didn't mention it was function 3. I think, well, but of the on-demand erection thing, I never really used that. I think I tried it out of curiosity once and had a slight leak because there might have been a little bit of residue in the bladder. So at the very point of when what you're wanting it to do, it does quite the opposite. So I never bothered with that. I went down the injection lines at the time, and that's been my experience of it. So I'm happy to answer any queries or concerns anyone might have. I've certainly no regrets whatsoever. I'm quite taken aback at how curious and rare it is for people when they stumble across it, and some clinicians have rarely, if ever, heard of it. So my experience have all been positive. I've flown all over the world, used it all over the world, and it's particularly in places where there's little or no access, whether it's been a bottle or a sheath and a bag, it's enabled me to, live a very, very fulfilled life. Mm-hmm. So I hope that was of some interest to you all.
Yeah, great. Thank you, Graham.
Thank you. Yeah, it's been really good. Thank you, Sean and Graham. We do have 2 questions in the chat, which I'll just ask. I don't know whether you want to answer about the criteria for being eligible for the stimulator, because Hayden, of the question about incomplete. Yeah, from Hayden.
Hayden's asking someone with an incomplete C5, C6 have this procedure, having AD and sensation, suprapubic catheters since 96. So, I mean, it's not indicated for people with incomplete injuries. I think I had up on my slide that about 10% of people that have had the device have had incomplete injuries, and that's a mix of people from the very early days before they used rhizotomy and people who have been prescribed the device off-label by clinicians. So it's technically possible, but there is a bigger trade-off in the rhizotomy because you would lose sacral sensation. So people who generally opt for the device with a incomplete injury are kind of having really significant problems with other areas where they really just, they want a solution, don't mind about those losing some function as well. So, but the best course really, you'd have to have a clinician who's kind of talks you through it and agrees to do the procedure. Off-label, I mean, I hope that answers your question, Hayden, but feel free to shout out if it doesn't.
Yeah, and Hayden, if you want to afterwards have like a one-to-one discussion with me about that, I'm more than happy to do that. If you want to contact the spinal cord injury nurse specialist email address, and I can call you back to discuss that in more detail from a personal perspective. And then Peter has said that he missed the start of the talk, and what has brought about the renewed interest into the bladder stimulators, and why hasn't there been some UK longitudinal studies done? I don't know whether you want to answer that, Sean.
Yeah, I can try. So I suppose the renewed interest was due to some demand for it, and some people, I suppose the reason it died out in the UK primarily was that people were retiring who offered it. So Peter Teddy and Ali Jamous, for example, at Stoke Mandeville, the service stopped when they retired. And the person starting the Oxford service is someone who was kind of one of Peter Teddy's assistants and is now the lead neurosurgeon who wants to restart things. So there was my understanding is it was primarily a kind of generational issue. And longitudinal studies, I don't know why, it's a good idea to do them. There have been quite a lot of longitudinal studies from other countries. My understanding in the UK is just that it's been a relatively small number of patients and quite fragmented, but it would be a good idea to do them. There were longitudinal studies up to the first, I think Brindley published the first 500 patients, which included a significant number from the UK. But it's 40 years, FineTech is 40 years old this year, and I know there's some more efforts to look at worldwide longitudinal studies of the device. So I can see there's another question at the bottom of that. Will the new service be significantly more patient-focused than the haphazard approach? I would hope so, yes. It's not me leading the new service, but certainly we're including more patient groups like SIA, and the way devices like this are prescribed has changed quite a lot since they were originally introduced, particularly the consenting procedures and I don't know whether that answers that particular part of the question. Yes. And
there's a question, I think, for Graham from Gary asking, have you had any issues taking it through security at the airport?
I've just seen that one myself, and no, I haven't. I was going to dash and get it then, but I think it's in my home file. I have got a small passport-sized piece of card from Professor Brindley or FineTech explaining what the device is. The holder of this device uses it to whatever, and yeah, it's in English, so I suppose I have to understand that. But I do carry something with me tucked in my passport that explains what it is when they look at it very weirdly and curiously and thinking it's obviously a device to set something off. Well, it is, it's me, but not anything untoward. So yes, there is that has obviously cropped up and been addressed by this passport-sized explanation diagram for such issues, for security issues. Yeah.
Okay, thank you.
Thanks, Graham.
And then there's a question: what kind of function would the incomplete lose?
Yeah, so primarily it's sensation. So the rhizotomy or the sacral deafferentation I talked about essentially involves physically cutting the sensory nerves as they enter the sacral spinal cord between S2 and S4, sometimes S5. Which essentially abolishes any sacral sensation, along with those reflexes that contribute to overactivity in the bladder and sphincters and bowel, and autonomic dysreflexia. So they would, you would lose kind of pelvic sensation. And that, I suppose, depends on how good the sensation you have is. I know some people, it might be pain. So it might be good to lose some sensation. The other side of things, which would be both for people with complete and incomplete injuries, is if they have reflex sexual function, which is kind of useful, which some people do, such as reflex erections or reflex ejaculation, and reflex bowel function, if that's useful, rather than the opposite, they would be lost because these reflex arts are basically being cut. So it's a crude but very effective solution that was has stuck because it works well for a lot of people, but it's also limited the uptake because lots of people don't want to lose those functions, particularly younger people and younger males who kind of care about reflex ejaculation in particular. So solutions after the rhizotomy Graham alluded to is things like injection for erectile function should still work in the same way, and you can have implant-driven erections, and for ejaculatory function, the electroejaculation, I'm not sure where it's still offered, but that should still work, even if it's not very pleasant.
Yeah, I can concur that it's not very pleasant, but it did work. Yeah. And it's quite an extreme thing, but it was successful with myself.
Yeah.
And just there's that little certificate thingy that I was explaining about, and just what it does. And then I think it's another bit about who you should contact if you find it. And the implementation was actually done by Mr. Jamil. I don't know if you know that your name familiar with, and a neurosurgeon and neurologist, and Matt Williams, the neurophysicist, Matt Williams, who recently retired, I think, at Pindus.
We've got another question from Norman. Norman, I think this is what Sean's talking about incomplete lesions. The fact that you have full bowel control, I don't think you would actually get a surgeon that would cut them nerves, which is what's required. So what we're saying is, if you're having this implant, the nerves are cut that control the bladder and bowel. So that means that you will lose all control of your bladder and bowel. And those that have reflex bladder, which means they can use suppositories or enemas to empty their bowel, that will no longer work, and they would just have what we call a flaccid bowel, and so would therefore have to use the stimulator, and still may require digital removal of feces. So I hope that answers your question.
There are other implants not targeting people with spinal cord injury that may be possible for people with incomplete injury for incontinence only, and it's something you could ask your urologist. I think there's a hand up.
Yeah, Stephen, and then I think that's then going to bring us to the end of the session. So if there's anything anybody else wants to ask, they could maybe email us, if you email into SIA. So Stephen, do you want to ask your question?
Yeah, thank you, Sean and Graham. My question, this is a very rudimentary way of doing it. It's like quite a blunt instrument. Is there any newer ways of doing it? Are they looking into a newer ways that isn't bladder and bowels in one go or anything like that? I've got loads of problems with my bladder at the moment after 30 years. It's been very good for 30 years, but I'm having all kinds of problems. So yeah, are they looking at newer ways that's slightly less blunt?
Less in, yeah, that's a good question. So that's really what our research in UCL and Stanmore is focused on. So firstly, there's nothing available at the moment that uses electrical stimulation for people with spinal cord injury to control the bladder and bowel. There's a series of projects looking at different things. So the one have been working on is using genital nerve stimulation specifically for incontinence or low bladder capacity. And that's using small external electrodes and is applied to improve bladder capacity. And we've got a trial if you're interested in trying that kind of thing. We also have a trial looking at spinal cord stimulation using non-invasive spinal cord stimulation to look at both voiding and continence, so control over continence. And that's just starting in Stanmore again now. Involved in a study in Salisbury Spinal Injuries Unit, which is available to everyone, I think remotely, which is using abdominal electrical stimulation to improve peristalsis and constipation, which is quite exciting. I think that there was an article about that in Forward magazine a few months ago. And relating to implants, there's a study at Oxford at the moment where we're looking at, like you say, trying to do some finer control of the bladder and bowel without this kind of cutting the nerves. So there is quite a lot of activity and quite a lot of promising work, but there's nothing that you could go and kind of have prescribed or buy as far as I'm aware at the moment.
Lovely. Thanks very much, Sean. So I'm afraid we've run out of time. So I would want to thank both Sean and Graham for sharing the information and their experiences with us. The link is, if anyone has got other questions, the link is in the chat, an email that you can send to. And I would just ask that if you've enjoyed the cafe, please share it on Facebook, Twitter, let people know that it was interesting, and we can help hopefully have more people coming and joining us. So thank you all very much.
Yeah, thank you. Thank you, Carol and Graham. That was really helpful for you to join.
My pleasure.